So lots of opportunities now to have a wider panel discussion. So I'm going to ask our previous speakers to join us. So Lewis and Ian. We're going to be joined by two members on the panel. That includes Helen Undy, the Chief Executive at Money and Mental Health, but also Professor Jenny Shaw. Helen, I wondered whether you could start by just introducing yourself.
Yes, of course. Thank you for inviting me. Thank you to Lewis and all of the team for this fantastic report and event. So I'm the Chief Executive of the Money and Mental Health Policy Institute. We are a research-led charity that aims to better understand and practically tackle that link between financial difficulty and mental health problems. And that has included quite a focused look at the link between economic factors and financial difficulty specifically, and suicide. So we know that people in problem debt are 3 times as likely to have thought about suicide in the last year, and understanding why that is and the range of kind of both short and long-term drivers and where practical action could make a difference has really been a big focus of our work for several years, but increasingly so during the cost of living crisis. So I'm really delighted to be able to come and have an opportunity to share a little bit of that with you today as well.
Thanks, Helen. I do hope that you'll have an opportunity to maybe highlight people to resources in the chat box as well. So we're really pleased to have you join the panel discussion. Jenny, would you mind introducing yourself as well for the audience?
Hello, everyone, and thank you for wonderful presentations today this morning. I'm Professor of Forensic Psychiatry at Manchester University, and I've been a member of the NCISH team since its inception, largely focusing on the homicide aspects, but also more recently on a study we are conducting on service users in alcohol and drug services. I also have expertise in the mental health and systems of care in the criminal justice system, including self-harm and suicide. Thank you.
Thanks, Jenny. And I'm going to start actually, not surprisingly possibly, with a question for you, Helen, if that's okay. So we've clearly heard a lot of concerns about the cost of living crisis, economic adversity. And for people listening, what sort of support and resources are there for people experiencing debt or concerns about financial adversity? Where would you signpost people to?
So there is an awful lot out there, and I think that's one of the good things about this conversation is that in the UK, we have a good debt advice kind of charitable sector that is should all be free at the point of delivery to the individual concerned. So you can go to places like Citizens Advice, Step Change, National Debt Line, depending on whether the person that is concerned prefers to get in touch by phone or go face to face. And we know that different access channels can be useful for different people, particularly when that's interacting with your mental health. So there is a range of different ways of getting in touch. But we do know that people tend to leave it. I think the figures show about 18 months to 2 years before they would first benefit from debt advice until they actually go and seek it when they do. And part of that is around barriers to accessing advice. There can be waiting lists or kind of services that feel inaccessible. But a lot of it is actually about not knowing what's out there, not feeling like you deserve it, not feeling like your problems are great enough. And the more we can integrate those services into mental health services, the better. So there are some really great examples out there of integrated money and debt advice services within the mental health system, but it's far from routine and standard. So we'd really like to see everyone who's accessing mental health services being asked about their financial situation and then being signposted at a minimum into good, accessible money and debt advice, which does exist.
Thanks, Helen. I think that's a really important take-home message from today's conference. I wondered whether I could move over to you, Jenny, with a question. We've heard from Lewis about the risks attached to alcohol and substance misuse. I wondered whether, you wanted to say a little bit more about the research you're undertaking. And then also there's a question about whether suicide rates for this particular group have actually increased since COVID. Do you have any data on that?
Thank you, Pratibha. So firstly, about the study that we're conducting at the moment, we will have results from this study towards the end of the year. And this is quite a novel study looking at suicide in service users in alcohol and drug services. So we will be able, by the end of this study, to look at risk factors for suicide in this group of people attending these services. And also, very importantly, as I've noted in the chat, there's been a lot of reference to dual diagnosis. And we will be able to cross-reference our NCISH database on mental health services and look at this group of people who are under both sets of services, so alcohol and drugs and also mental health services. We haven't got results at the moment, but just to say that the study is going very well. It's a sort of data crunching exercise and also looking at serious untoward incident reports. But we should have some results, as I say, towards the end of the year, and hopefully maybe a presentation at next year's conference.
Thanks, Jenny. I think people will be looking forward to that. A few questions, I think, for you, Lewis and Nav. The first question, Lewis, was partly about the data you presented. So a quick question, was the data that you presented by financial year or January to December? So calendar year.
Calendar year.
Calendar year. That's quick, easy clarification. There was also a comment about the key groups that you identified as being at risk, in particular kind of risks like online harm. Why was gambling not included, given some of the associations or concerns?
Depends what you're talking about. We haven't always asked about gambling, but if you're talking about the service interventions, these are about services, so they transcended what problems people might face. So if you take the 10 ways slide, for example, which is a summary. So I didn't spend a lot of time on the 10 ways methodology because it's actually quite complicated. But what we're trying to do, and we've done 2 or 3 studies on this, we're trying to track patient suicide risk over the years during which we've been collecting data and relating changes in suicide rates to the changing configuration of services. So the focus is not on the causes, but on the service response. And that's because if you think back over a number of years, and certainly when we started, just now 25 years ago, people used to say, well, the effect of services is probably quite marginal. There is a kind of fundamental risk attached to mental disorder, and the effect of services is quite marginal. So we decided to monitor how services changed and how this related to patient suicide rates year on year. And that slide of the 10 ways is a summary of the strongest associations with falling patient suicide. So it's not actually about the causes that might have lain behind it. It's more about what services need to do in response.
Thanks, Lewis. And with the sort of falling rates, particularly for patients, there was a question about whether there is any underreporting, so whether some of those deaths are more likely to be reported as misadventure. So someone was talking about their son who had got a diagnosis of bipolar, who ended up with a misadventure verdict. Do you think that's a risk, and that's why we're seeing falling rates sometimes within mental health services?
I think it's a risk. I don't think it's the reason we're seeing falling rates. There's no question suicide has always been underreported, and there are various reasons for that. And sometimes it's about an inference at inquest about family sensitivity. So in other words, coroners feeling that this suicide might be a very upsetting verdict for families to have to accept. In fact, in my experience of talking to families and listening to families, they have, well, first of all, there is no single family view, I should say, but a common family view is that accuracy and truth is more important than sort of euphemistic response from the system. So I think the underreporting certainly has been around. The other reason why underreporting has always happened is that the legal system essentially imposed an underreporting by setting a high threshold. So until 2018, the threshold for a suicide conclusion at inquest was the same as in a criminal trial. It was beyond reasonable doubt. And following the campaigning of a number of charities, in particular, lots of people in suicide prevention felt this was an inaccuracy. for the reason that's implied. So the underreporting the figures, and so that changed. It changed almost by accident in a way because of a particular case. So it changed by precedent. But in fact, as a result of that, the underreporting has been very significantly reduced. Historically, suicide figures like ours always include deaths from undetermined cause. So they're deaths where the coroner didn't feel the threshold had been reached. More recently, that's become less necessary because the change to a standard from beyond reasonable doubt to balance of probabilities. So underreporting is definitely there. It's probably still there, but it's getting less. Is it the reason why the figures have gone down? No, I don't think so, because those figures year on year are dealing, they are more or less affected by the same level of underreporting if you compare one year to the next.
Thanks, Lewis. And I guess from my own sort of perspective as a child psychiatrist, do you have any kind of comments? You were seeing that rise in suicides in young people. Do you think that's changed at all because of the change in the burden of proof happening in 2018, or will we see an increase prior to that change?
Yes, it's a really important question, because the rise that everybody, I suppose, has heard about in young people, particularly in the under 20s, from around about the late 2000s, 2009, 10, up until essentially for the next 10 years. That rise probably had several factors behind it. And then in 2017, 18, the legal change came in 2018, but it affected deaths from 2017, which hadn't yet come to effect. So there was an additional jump. So there's a longer term rise in young people suicide, and then a jump around about 2017. And that jump is more related to the change in verdict. Incidentally, the most recent figures suggest a leveling off of child suicide rates. So it looks as if the most recent figures, it's only partial positive news, because the rise has already happened. But on the other hand, it doesn't seem to be occurring in the last or continuing in the last 2 or 3 years.
Thanks, Lewis. And a question for Nav about risk prevention and risk assessment. Do you understand the reasons why we're not identifying risk for people in contact with mental health services? So you highlighted that in a number of those situations, the risk was classified as being low. Are there particular reasons for that, do you think?
We've written extensively on this and talked extensively about it. It's to do with the fundamental problem of trying to classify risk in a simplistic way or to score risk. Inevitably, it's the needle in the haystack paradigm. It's picking that one person who will actually, sadly have a kind of tragic outcome out of the 100 people that you see, all of whom have the so-called risk factors that you might think are important. So this idea of the needle in the haystack problem, and the problem with risk assessment is not that we need to do it better in a sense, because we'll never be able to pick that person, but it's about better care for everyone. So, one of the things we often talk about is, if someone comes to mental health service, and many of the people on the call are working in mental health services, if a person comes to mental health services, they automatically are kind of high risk. So it's a bit like the make every contact count, better care for every single person rather than trying to pick people. So this isn't about doing risk assessment better. There was something in the chat about machine learning and risk assessment. Machine learning isn't going to be able to kind of, if you like, solve the problem. The prediction gets slightly better if you use supercomputers, but this is about what's useful on the ground. And the other big problem with the risk assessment paradigm, which we see again and again, is it is all those people rated at low risk who get excluded from care. So the big problem about risk assessment, not just is the needle in the haystack problem, which is to predict people, but the bigger problem is all the people you exclude. So I think this is about, better systems of care. Lewis's slide of 10 ways of working, I think that's the way forward.
Thanks, Nav. So that sort of stronger focus on personalised and sort of more compassionate and collaborative care as well. There is a question about whether the NCISH really does focus on people or patients in contact with mental health services. Does there need to be an equal focus on people not under mental health care, and how would that happen in practice, really?
I think we've been focused NCISH itself has been largely focused on mental health safety. And I think that's important, because if you prevent suicide in mental health services, that's safer care for every single patient at mental health services. But we also do lots of other studies. Quite a lot of what you've heard from my presentations at previous conferences is to do with everyone who dies by suicide. And I think, you know, it's about different areas of focus. So middle-aged men, really important group, children and young people. Those weren't studies of just patient contact. I think one area where we have kind of, things, there is a real opportunity, I think, is primary care, and that's why I highlighted it. I think that could be a real kind of area.
Particularly, I think it's an important point. We do quite a lot of studies that aren't about patients, but if we are going, one of our primary messages is that we need to be able to make services more receptive. People should be able to seek help. We can't keep trying to bring people into services if we haven't also made them as safe as they can possibly be. What's the point if services themselves have sufficient gaps that people fall through? So we have to do both. I think we would say that we've had a focus on those groups who are less likely to go into services, like middle-aged men, as now said, and also young people, where our own data suggests that they're less likely to have sought help through specialist mental health care. So it's absolutely, the point is absolutely right, but I think we need to do both. We mustn't suggest that somehow there should be a shift away from mental health care. It remains the core of suicide prevention nationally.
Thanks, Lewis. There are a number of questions about the diagnosis of personality disorder. So one question was, it's often underdiagnosed in children and young people. So does that partly influence some of the data that we're seeing, that we're not sort of reporting high rates of personality disorder diagnosis in young people? That was one question. Interestingly, for adults, they were just people reflecting on the rising rates of that potential diagnosis in adults, and whether that shift might be more correct sort of diagnosis. Were these people that previously would have ended up with a diagnosis of bipolar disorder? So I don't know whether you want to pick up the issue of diagnosis at all. It's always a complicated one, and particularly as people transition from children's to adult services as well, I think.
Perhaps I could say a word, then I'm going to pass on to Jenny, who actually led some of our personality disorder work in previous years. So I think it's an interesting point, because obviously we are picking up information from clinicians. So if diagnostic practice changes, then we will detect that change, and we will have to consider that changes in numbers are not always a change in risk. There might be something about changing about the nature of clinical practice. I mean, I hope it's true that people are reluctant to diagnose personality disorder in young people, because what it conveys is a kind of therapeutic pessimism, an enduring set of characteristics that services will struggle to work with, and that isn't a good message to give to young patients. I mean, I believe that part of this is about how society responds to people who don't always reflect the way that society expects us to behave. So that society has always had ways of describing people who are sort of on the margins, who it feels less supportive of, who feels they've caused their own problems. And those people in the system have always got a bit of a raw deal from care. And that's true whether we refer to them as personality disorder, or for some people, they are sometimes people with neurodevelopmental disorders have historically faced the same kind of issue. So the names do change, but the concept that lies behind some of this is a concept of not really having a place. There isn't a place. We don't have a service for you. We haven't got something to offer you. We haven't got the evidence. We can't support you. And it's that we have to be able to overcome.
Thanks, Lewis. Jenny, did you want to add anything from the work you've done?
Yeah, just very briefly, the study that Lewis referred to, the qualitative study, was particularly interesting, and it brings up, I think, something Lewis referred to about, do we make this diagnosis or not, and what's the benefit or otherwise of doing so? And I think there's lots of argument about the benefit or otherwise, but in that study, what people said to us was that it is helpful to have a diagnosis or a formulation and to have associated treatment, because what people shared with us in that study was that services were quite good in a crisis for people, you know, who would self-harm maybe, and for people that really engage very well with psychological services. But in between, there was a massive gap in service provision, and that was the key finding that it was felt we needed to address.
Thanks, Jenny. And Ian, you've raised the kind of issues around online harm, and I did wonder whether you think there's more that we need to do working with parents and carers to increase awareness, but also whether you feel that clinicians really are aware of the kind of risks attached to online harm. Any comment from you?
I think the subject of online harm is so difficult to grasp. I've been looking into it for 5 years, and I feel I'm not just rushing to learn, but rushing to keep up as well, because just as you're learning about the harms that one platform can bring, particularly to young people, for example, another platform comes along. So when Molly was alive in 2017, TikTok, I don't think had been invented, and it's here now, and it's like all platforms is a potential source of online harms. It's very difficult to keep up. So in that sense, I think we all need to spend more time considering online harms, which is why regulation is so important, because there needs to be a central pool of expertise and pool of thought and a regulator that helps keep that in check. But just as I've learned that the stigma that surrounds the S word, suicide, that should all be broken down. We should be much more able to talk in civil society about these things. And I think from what I've learned, that would help everyone be better prepared and know how to react if they're confronted with someone who is contemplating suicide. Just as that stigma needs to be broken down, we need to somehow battle with the online harm stuff as well, because there's a sort of similar tech stigma that goes with that. So I'd recommend everyone spend some time finding out what they can about the harms that can be found, and they can be found still today. The same harms that Molly saw in 2017, they can be found today online very easily.
Thanks, Ian. And you'll have followed the kind of campaign of the 3 dads that were on the BBC this morning. So what are your thoughts? I mean, clearly they're raising awareness about talking about suicides within the curriculum at schools. What are your thoughts about that, making that mandatory now within the curriculum?
Well, I completely support the 3 dads in that respect, and the Papyrus campaign. One of the most important things is that we're all better informed, and digital literacy and the effects that the digital world can have on all of us, each of us as individuals, something everyone has to think about. A lot of the digital products are designed to be addictive. They're designed to keep you on the platform for as long as possible, so that the advertising dollars can be made. And we need to be aware of that. We need to be aware when we're being used by the platforms. We need to put our phones down more quickly. And so campaigning, including that in the curriculum, so that from the earliest age, young people are beginning to become aware in an age-appropriate way, and parents are supported in learning as well. I think that's an absolutely vital thing.
Thanks, Ian. And Helen, I guess there's been a question, you know, we've talked about providing support for people in contact with mental health services, but what about the wider public? Clearly there's going to be a lot of anxieties around coping with the cost of living crisis. What kind of advice or information would you want to put out there?
So, I mean, we've already talked a little bit about signposting and the kind of information we'd want out in terms of where people would go to. I think it's really crucial to focus a little bit on what it is that's actually affecting people, because we talk about economic adversity as quite a large concept, which bundles in lots of things together and can make it quite hard for people to know where you could actually make a difference, because as clinicians or as a local authority public health lead, you can't, other than with your own spending power, you can't really influence the economy. So you might be sitting there looking at it thinking, well, influencing the cost of living crisis is outside of my potential area of influence. But actually, so one area where we found a very specific relationship is debt and financial difficulty. So actually, so people who are in financial difficulty are 3 times as likely to think about suicide. There's lots of things bundled in there, but even once you control for gender, age, unemployment, and a whole range of other factors, you're still twice as likely to be thinking about suicide. Just looking at debt, so just looking at being behind on one or more of those payments. And that rises significantly when people have multiple debts. So there is something about the size of debt that we're in, but there's also something about the number of creditors. And our research has found that there's a particular factor there around the contact that people get when they're behind on payments. So being contacted by multiple creditors, so it might be your energy company, your credit card company, mortgage provider, or your landlord. You might also be behind on kind of consumer credit, so buy now, pay later products, those sorts of things. Because for lots of people who are in financial difficulty, it isn't just one thing. It becomes, 7, 8, 9, and you're receiving letters, text messages, phone calls, and it can really feel like a bombardment. So one thing we're really keen to focus on is both, I mentioned that signposting into debt advice, and somebody in the chat has mentioned the breathing space scheme as well. There are quite quick ways that people can get some protection from that bombardment of messages. Debt advice charities can advocate on people's behalf. If you're using mental health crisis services, you're entitled to the mental health access mechanism for the breathing space scheme, which we successfully campaigned to get introduced, which means that you should get complete protection from interest charges, fees, collections activity, and contact from debt collectors for the duration of your care in mental health crisis services. And if you're not in crisis services, you can access breathing space by going through a debt advice provider. So focusing on what's out there at the moment to protect people from that, but we're also doing quite a lot of work to influence government, regulators, and financial service providers directly to do better at source. So to stop sending this bombardment of letters and messages. That's just one aspect of the picture, but it is one that came out particularly strongly, and especially in our research during the cost of living crisis as well, where we found that actually, so if you're looking in 2022, over the kind of first 9 months of 2022, we found 1 in 6 adults said that they reported suicidal thoughts or feelings specifically as a result of the rising cost of living. That was in nationally representative polling carried out in November. That goes up to almost half, so 49%, when you look at people who are behind on 1 or more bills. So, when we talk about targeted suicide prevention intervention, those people who are behind on bills is a really good place to be targeting interventions. And actually, just finally to Nav's point on AI, because I think that's really important. AI is only as good as the data you give it, but the place that I think should be using really good, smart AI to do targeted suicide prevention interventions is the financial services industry, because they're already using targeted AI to go through masses of financial data every day to spot where they can target marketing of products and services, and to use that to spot when someone's income stopped coming in, when they're gambling, when someone's spending at night. Those sorts of things are all perfectly within the realms of possibility. And we're starting to do work with some banks on what a good targeted intervention would look like when you spot the signs in financial data that somebody's much more likely to be struggling.
Thanks, Helen. I was just thinking those are all fantastic elements to consider in the suicide prevention plan that's coming out later this year. So I'm sure Lewis and lots of people will be scribbling notes about some of those recommendations. Thank you. There is a question about unemployment and the links to suicide. I don't know who wants to sort of pick this up. It was about whether the type of employment that someone's had prior to becoming unemployed actually makes a difference. So were you finding people employed in particular services, the police, fire service, the military, where there may be more exposure to trauma and PTSD? Was that at all a risk?
I'll maybe kick off there. It's probably not a major contributing factor to the overall suicide rate. So for individuals, yes, it can be a risk factor, but it probably isn't a major contributor to the overall rates. And specifically taking one of those groups who you might think would be at highest risks of PTSD, we've recently done a study of veterans, so all veterans in the UK over more than 2 decades, and looking at suicide risk. And actually, PTSD was slightly more common in veterans who were patients of mental health services and died compared with other patients. So it's something, but it was overall pretty uncommon. So it was about 3% overall PTSD. So I think, yes, absolutely important for individuals in terms of, overall rates, some of these changes we've seen, probably not the main explanation.
Thanks, Nav, and sort of linked to that kind of question about people's employment. I know there were concerns during COVID about rising rates of mental health problems with people working within healthcare services. And I know talking to nursing colleagues, they were worried about sort of rising rates of suicide in nurses. Is that a particular concern or a trend that you've seen at all in any of the data?
Lewis, I don't know if you want to take that one.
Well, the short answer is we don't yet know, although it is an important question. We're about to do some further work on suicide by people who are in the front line of health services, the NHS, not mental health, but the NHS more broadly. And one of the issues over the last couple of years that we will look at is people's experience during the pandemic. When people obviously had to work in different ways, it was often a challenge to the standards that they'd set themselves because of the decisions they were having to make about the use of resources and the life or death decisions that were occurring every day for people in certain kinds of employment. So I think the overall message about the pandemic that suicide rates didn't rise in the general population, don't seem to have gone up in patients. That doesn't mean that people's mental health wasn't badly affected. I think there's plenty of evidence that people suffered more mental distress during the peak periods of the pandemic. And I think we just now need to understand whether there were some groups within that overall picture where suicide rates didn't seem to rise, whether there are some groups who might have been put at greater risk. Occupational groups are a very important part of that, and the health service particularly. So we will know the answer to that soon. We have about 40 or so nurses dying by suicide every year in England. So it's already a significant problem. Nurses are the only group where we have clear evidence among health professionals that the suicide rate is high. Incidentally, the suicide rate in doctors is not high in this country. And so nurses are already a group of concern. They're already a group where we're seeing vulnerabilities reflecting a combination of working life and personal life, and where we already need to do more on prevention. They are the high-risk group within the health service that we need to do more about.
Thanks, Lewis. And I think it just re-emphasises the importance of being able to collect real-time surveillance data that picks up, I think, sort of key factors that might influence how we respond nationally. I am just conscious of time, and I know there's so many kind of questions still left in this sort of chat box. I think our team from NCISH will be trying to answer as many of those questions as possible afterwards through Twitter. Before we finish, I did want to give Ian an opportunity to probably just reflect on what you've heard, maybe think about some key messages for the audience listening.
Yes. Well, once again, thank you very much for asking me to be part of this event today. In the last 5 years, I've looked at NCISH and the communications that you send out, and I guess I'm a bit of a fanboy. I hold you in such high regard because what you say is academically rigorous and thought through, and always so informative. So just to be part of this event is amazing. The other thing is, as a person with lived experience bereaved by suicide, the comfort that I get, and I'm sure so many others get, from knowing that there are so many people working so hard to make suicide, the numbers reduce and those statistics go down, is amazing. From my point of view, I would say please do look at the online harms. I know you do, but always have them in the back of your mind, whatever you're doing, and try not to think of them as harms, as bits of isolated content. Some of the stuff that Molly saw on its own is marginal. Is it safe? Is it unsafe? It was when they were combined and amplified by algorithms that I think they became dangerous. Molly couldn't escape them. In fact, one of the platforms went so far not just to suggest similar content to her on the platform, but it also sent Molly emails saying something like, you liked lonely, depressive. Do you want to think about sad anxiety as well? Do you want to follow this other account? And it's the effect of the systems behind the platforms that I think are the most dangerous. And at this time, those systems are changing very fast. Snapchat, I gather, Snapchat has already introduced large language AI into its platform. So you can chat with a virtual being 24/7. There's always someone there to chat to. And I think there's evidence that that has already led an account set up as a 13-year-old's towards a sexual abuse situation. So we all have to be vigilant, and we all have to be careful, and we have to be aware of the pace that the world is changing at in terms of technology. But it's a great comfort to have the knowledge that there's NCISH and people that are on this call who are doing whatever they can to make the world, and the digital world in particular, I guess, a safer place. So thank you.
Thank you, Ian. And I wanted to sort of thank all of our speakers today, particularly you, Ian, for sharing your personal story. I know it's had a huge impact on people listening, incredibly powerful. And I think people just really inspired how you've really kind of taken that story and made changes around suicide prevention. So thank you. Also, thank you to all of our colleagues from NCISH, Lewis, Nav and Jenny, but also the team behind them. Undertaking, you know, lots of the research, but also supporting today's conference. Huge thank you to you, Helen. Lots of fantastic practical advice, and the fact we've got this recording means that we can go back and just look again at some of the suggestions you've made about support. I wanted to just finish with just a few personal reflections, if that's okay. It is increasingly clear that suicide is really complex. It's rarely ever one single factor, and therefore for suicide prevention to be really effective, I think what everyone sort of made clear is that each and every one of us has a role and a part to play here, whether that's us as clinicians, whether that's wider agencies. I'm thinking, Ian, talking to you about the role of schools, the role of other agencies, the role of government, Helen, in thinking about what more we can do around supporting people facing financial adversity, but also how we support the wider public. And again, there were some really, I think, helpful practical considerations about what we should do, including working with parents and carers. The research has identified particular themes for people who come into contact with mental health services, people who self-harm, the role of alcohol and drug misuse, social isolation, as well as financial adversity, and where those risks might be greater for certain vulnerable groups. So we've heard about the particular concerns about people with a diagnosis of personality disorder, people identified as being LGBT+, or who are neurodiverse, and maybe the risks are actually slightly different for children and young people under the age of 18. I think that's important for us to remember. Some personal sort of reflections, things that I think I'll very much want to do differently, just really think about how we have effective family involvement, really recognising periods of risk. And Lewis has identified post-discharge, particularly within sort of 3 days of discharge. The opportunities is the other key message that's come through. So for people who've self-harmed, do we have comprehensive self-harm services 24 hours a day, 7 days a week? Do we have services that are really accessible, particularly for some of our communities at risk of health inequalities? And that move away from using risk assessment tools to that more personalised, collaborative, compassionate approach, making sure that we've got robust aftercare. Ian and others have highlighted the importance of asking about online harm. That's something that I have to say I am going to do differently in my day-to-day practice. Please do consider that within your own practice. Samaritans have got some great resources around reducing online risks. We've heard about financial adversity, and it's been fantastic to hear from Helen about some really practical things that we can think about, but making sure we're asking about financial adversity at every appointment, because those risks change. Lewis has mentioned the great resources at NCISH, so please do look at their website, that Safe Vet Services Toolkit. So I'll finish there. Thank you to all of our speakers, but a huge thank you to everyone who's joined today for all the work that you do around suicide prevention. Please take the time to also look after your own mental health and well-being. So thank you and enjoy the rest of the day.
Thanks, everyone. Bye-bye.